Regarding the advances in the surgical field, should the TME done by open laparoscopy or robotic? Would you comment on that?
Yes, well, in my older age, I only do open surgery personally, but I take a very major interest in the potential of laparoscopy. For years I've been interested in laparoscopy, and I'm very proud of having a chair of laparoscopic surgery, which I don't actually do. I have colleagues who do that. The perfect professor who is not actually doing what he's professing. But laparoscopy does have clear advantages, especially with modern high definition vision. After all, the whole TMA idea was about embryology in the first place, defining planes, and then seeing where you cut instead of blind extraction with the hand, which used to be the standard method. It was like trying to pull a rabbit out of a hat, and the assistant never really saw where the planes were being breached, where the nerves were being torn, where the surface of the mesorectum was being torn into. So to see better and to do sharp dissection under direct vision is the very principle of TME. And if laparoscopy can do it better in your hands, then that is the way to go. But at the moment, I think one has to say it's a pretty level race, with a new outsider coming in the form of the robot. I have a colleague, Mark Gudgeon, who has used the Da Vinci robot to see the two layers of Denonvillier's fascia. We'll come to all of that in the course of our DVDs. But it's unusual to see both layers separately defined, and he has done that with the robot. So there's a possibility that the wonderful three-dimensional vision in high definition, combined with the infinite flexibility of the instruments, may mean ultimately that some of these key things, the perfect TME, the perfect preservation of nerves, the avoidance of unnecessary stomas, the avoidance of unnecessary radiation, all of these things may ultimately be done better by refining the tools, refinement of tools, but confusion of aims, Albert Einstein said, was a feature of his time and still in our time. The aims remain the same. We've repeated them. Perfect cure, perfect lack of damage to the autonomic nerves, and audit by the pathologist to confirm all that. Workup using MRI particularly. Gina Brown has contributed a section to help you realize the potential of MRI in planning which people need radiation before their surgery and avoiding it if they don't. All of these are really important things, and MRI can also help a whole new field of anatomy, bridges between cadaver anatomy, MRI anatomy, and the morbid anatomy that the pathologist helps us with. These are all important bridges.